Oh, my name is Miss Hahn, and I am going to go over chapters 15 and 16 from your fifth edition Ricci textbook. And this series, this lecture is called Postpartum Boot Camp. Now, I love the picture that is on this first slide. It kind of tells a hard truth that sometimes, as a new birthing parent or mother, how you feel. So, and it's really more how you feel about yourself. And so, what her board says is sometimes it is hard to love my new body. And I want to remind that for many birthing parents, the way our bodies look right after birth will change within the year. Sometimes clients will get back to very similar to what they were before pregnancy, and other times they don't. So I just want to just point out that as a nurse, we have a wonderful opportunity to let these clients know that the way they feel about their body now may change as time goes on, as their body heals and starts feeling like it's going back to normal. So let's get started. The postpartum period is also termed the fourth semester or fourth trimester, not semester, but fourth trimester. And we also call postpartum puerperium. So it's really truly a critical transition period after birth for not only the newborn and the family, but also for the birthing parent or the woman, physiologically and psychologically. So puerperium is the period after delivery of the placenta, lasting for 6 weeks. And this period changes in all aspects of the mother's life that occur during the first year following the birth of a child. So again, there's going to be physiologic and psychological changes that occur during this time frame. And during this time frame, the birthing parent and the family are just getting adjusted to their new little family member and what that means to their previous relationship and how that correlates now. So, as far as our reproductive system adaptations are concerned, what occurs with our uterus is called uterine involution. And this is the return of the uterus to normal. And it is a gradual process. So usually the uterus will shrink back down into the true pelvis by around postpartum day 10, unless there is something going on like retained placental fragments or something of that nature that's inhibiting normal uterine involution. Uterine involution involves 3 retrogressive processes. The first one is contraction of the muscle fibers to reduce those previously stretched during pregnancy. Next is catabolism, which shrinks the once enlarged individual myometrial cells. And then finally, we have regeneration of the uterine epithelium from the lower layer of the decidual after the upper layers have been sloughed off and shed during the lochial discharge following birth. So, as you can see in the top figure with the postpartum torso, it is not uncommon for right after birth for the fundus or the top of the uterus to be at the umbilicus or slightly below. And then we count this in finger breadths below or above the umbilicus. So, as you can see, with each postpartum day, it should shrink down further below the umbilicus until by the time we're at postpartum days 9 and 10, the uterus is now shrunk down and back into its little, the pelvic area where it has its nice safety measure of the bones around it. So during the postpartum stage with our reproductive system, not only does the uterus go through involution, but we also have bleeding called lochia. And it doesn't matter what stage of lochia we're at, it should only have a slight fleshy smell, not fishy, fleshy. If it's malodorous or offensive odor in nature, that means that there's usually an infection going on. So it's not malodorous, it's usually just kind of a fleshy smell. Lochia rubra is the first stage of lochia. It's a deep red mixture of mucus tissue, debris, and blood, and it occurs for the first 3 to 4 days after birth. Lochia serosa is the second stage, and it's that pinkish brown serosa looking fluid that is, or discharge, that's primarily leukocytes, decidual tissue, red blood cells, and serous fluid. And you see this occur between days 3 and 10 after birth. And then Lochia alba is the final stage. It is a creamy white or light brown discharge that consists of leukocytes, decidual tissue, and reduced fluid content. This usually begins between days 10 and 14 after birth, but it can last up to 3 to 6 weeks after childbirth. Now, whether you have a vaginal delivery or a cesarean section, our lochia is expelled. Now, it can be very common for a cesarean section to sometimes have lighter bleeding than a vaginal delivery, but that's not always the case. It depends on some different variables, like what number of baby is this for the client, and those things we look at in regards to tone, tissue, trauma, and thrombin. So just like for a vaginal delivery. After pains are where the uterine contractions constrict the intramyometrial vessels that help to impede the blood flow and prevent hemorrhage from the placental site of separation. If the contractions are inadequate, then uterine atony occurs, causing postpartum hemorrhage. It is very common for all women or birthing parents to experience after pains. It can be due to being given Pitocin immediately postpartum. the flow of oxytocin normally through the body, especially for the breastfeeding um, client, because breastfeeding causes the uterus to contract due to the release of oxytocin, which is our uterine contraction and milk letdown love hormone. Um, so this is often why the healthcare provider will order a PRN or a scheduled oral, maybe sometimes IV analgesic after childbirth for the clients. And it's not uncommon for the more children a birthing client has delivered, the more acute the pains can be. And I can attest to that, especially by the time my after pains were worse with my second child than my first. And it seemed like they lasted that full week. And then with my third one, they were even worse. And my bleeding was a little heavier too. It never was a dangerous, excessive level of bleeding, but it was definitely much heavier compared to the previous two births that I had. So the cervix, it gradually closes, but it will never regain its pre-pregnant appearance. So immediately after birth, the cervix is shapeless and edematous, as well as easily distensible for several days following delivery. The internal cervical os gradually closes and returns to normal, but the external os, which is what we can see when we do a speculum exam, is the external os of the cervix. It never appears the same after being dilated or having childbirth. So the bottom picture shows the A and the B, the cervix. A is a cervix that's never been dilated or had a baby before. You can tell because it looks like a perfect little, almost perfect little pupil. But when you look at B, we can tell that this client has had cervical dilation. It shows that the cervix has returned to a jagged slit-like opening. And so it looks like it's winking at you. It'll never go back to that small, roundish, oval looking shape. Our vagina changes as well in the postpartum period. The mucosa after delivery is edematous, relaxed, and thin, and there's few rugae shortly after birth. But thank heavens for our estrogen hormone, because as our ovarian function returns, estrogen production resumes, and that usually takes around 3 weeks to see an impact in the thickening of the mucosa and the return of the rugae, which is those folds or ridges inside the vagina. But it's going to take 6 to 8 weeks to return to its approximate pre-pregnant size. So, have you ever heard the saying, nothing down there is ever the same after having a baby? Well, the vagina will always remain a bit larger after delivery than it was before pregnancy. Now, the perineum, it will stretch to allow passage of the neonate, and there's usually some edema and maybe even some bruising for the first couple of days or so after vaginal delivery, or in the instance where that birthing client pushes for a while but ends up having a cesarean section. We also have to look at if the client had any kind of lacerations or episiotomies, because that can literally take up to 4 to 6 months, or if there's complications, longer for that to completely heal. So you start healing much sooner, but it doesn't completely have complete healing and for many months. So the tone may or may not return depending on the extent of the injury of the muscle. And then tag on some swollen hemorrhoids that can add to the discomfort. So, how we manage this as a nurse for our clients is that we assist and educate on the use of ice packs, the peri bottle, squirt bottle use with each time they go to the restroom, the use of the witch hazel pads, any anesthetic sprays or gels that can be used down there that's ordered by the provider, and sitz bath use to help relieve perineal pain. And remember, the ice packs, the witch hazel pads, any kind of anesthetic spray or gel, and sitz bath are all things that the provider has to give an order for. Pelvic floor dysfunction is one of the most common complications following a vaginal delivery, and this is why pelvic floor muscle training exercises like Kegels are important, since they help to improve tone, strengthen the muscles, and promote healing. One of the most underused things is pelvic floor physical therapy. And this can be ordered by the provider, and it's a specialized kind of physical therapy to relieve the symptoms of pelvic floor dysfunction. So we're starting to see a rise in the referrals for the physical therapy for pelvic floor dysfunction, but it's not as prevalent as I would really like to see it. So with the cardiovascular system adaptations, although the blood volume initially drops rapidly after birth, it usually will return to normal, so pre-pregnancy normal, within 4 weeks postpartum. Now, for a normal vaginal delivery, the blood loss we usually see an average of around 500 milliliters or less, and around 1,000 milliliters or less for a cesarean section delivery. However, when what we learn and what we teach is that any bleeding greater than 1,000 milliliters total, whether it's a vaginal birth or a cesarean section birth, is considered a postpartum hemorrhage. And so we'll go over that a little bit later. But I just wanted to throw that out there. How do we know the blood loss during the initial postpartum stage or that recovery phase? We used to get a qualitative amount by just observing the pads and the underpads and estimating, according to what we're taught, how much bleeding is on that pad. But that is not best practice. Best practice is to use a scale to weigh the pads, underpads, any kind of linen or clothing items that have blood on them. So you measure the saturated items, and then you get clean items and measure that, and you're going to subtract the weight of the clean items from the wet items, and that's going to give you how many milliliters of blood loss. And so the difference in grams from a clean pad and a lochia saturated pad is equal to the milliliters of blood loss, if you think about it that way. So our blood volume and cardiac output decrease, and it does take the cardiac output about 6 to 8 weeks to return to the non-pregnant levels. But we initially start to see it drop to pre-labor values within 24 to 72 hours with that continual rapid fall over the next couple of weeks. Plasma levels are also reduced through diuresis that occurs between days 2 and 5 postpartum. Our hematocrit levels should be relatively stable during this time. If there is an acute drop in our hematocrit level, then that is suggestive of a hemorrhage. Same thing with hemoglobin level. So an acute decrease during that time is not expected and should give you an idea that postpartum hemorrhage has occurred or is occurring. Although, as the cessation of red blood cell production occurs after birth, a slight decrease in the hemoglobin and hematocrit levels can occur for the first 24 hours postpartum, but they normalize within the following 2 weeks after. So we don't expect to see a steady large drop, but a slight drop. An elevation in the white blood cells occur during labor, and they'll remain elevated for 4 to 6 days postpartum, but then fall back to the 6 to 10,000 range. So our heart rate and blood pressure, the heart rate usually will go bradycardic after giving birth. And that can last for some up to 2 weeks postpartum, and it should go back to its normal pre-pregnancy heart rate by or after 3 months postpartum. If our client is tachycardic, that could indicate hypovolemia, dehydration, or hemorrhage. The blood pressure is decreased in the first couple of days, and then it goes back up to 3 to 7 days postpartum, and then to its normal pre-pregnancy. We do need to monitor for significant drops or increases in the blood pressure because that could indicate postpartum preeclampsia, infection, and hemorrhage. Our coagulation factors. The physiologic changes important to prevent blood loss in childbirth increase the risk for blood clots. And it takes about 3 weeks or so for that to go to normal. So during pregnancy, labor and delivery, and postpartum phase, clients are at a hypercoagulable state. So they are at high risk for blood clot formation. So that's why we don't want them laying in their bed all the time. They need to get up and move. Red blood cell production, which I talked about already. So I'm not going to go back over that. So within the urinary system adaptations, it's a gradual return of bladder tone, size, and function during the postpartum time as well. Glomerular filtration rate and renal flow increase during pregnancy and return to within normal limits by around 6 weeks post-delivery. Difficulty voiding and decreased sensation for voiding can be affected by perineal lacerations, generalized swelling and bruising in the perineal area and the tissues surrounding the urinary meatus. Hematomas, decreased bladder tone due to regional anesthesia, and diminished sensation of bladder pressure due to swelling, poor bladder tone, and numbing effects to regional anesthesia that's used during labor. Now, if a client's having difficulty voiding that leads to urinary retention and bladder distension, It could also ultimately lead to a UTI, but it can also lead to uterine atony, where it doesn't allow the uterus to continue to contract down and control the bleeding. So, what you will see is that it causes a displacement of the uterus. Usually, it pushes the uterus up above the umbilicus area and over to the right or the left. And it inhibits proper contractions because of having too much urine in the bladder. So that increases the risk of postpartum hemorrhage for a client. So urinary retention is a major cause of uterine atony. How do you know if the patient is having issues with urinary retention? Well, one of the signs would be frequent voids in small amounts less than 150 milliliters. Another is what I just talked about with the uterus, that it's displaced and higher than what it normally was before. So if the client is unable to void appropriately, we may have to get a provider order for catheterization, like a straight cath, to empty the bladder and restore uterine tone. So diuresis begins within 12 hours postpartum and continues through the first week postpartum. Normal function will return within about a month postpartum. And a lot of the reason why we see what we see is because a lot of times clients will get a large amount of IV fluids during their laboring process and right after delivery, that oxytocin, as its level decline, it decreases the antidiuretic effect. We have a buildup and retention of extra fluids during pregnancy, and during that delivery phase, and a decreased production of aldosterone, which is our hormone that decreases sodium retention and increases urine production. For our GI system adaptations, our GI system will quickly return to normal due to the relief of pressure on the organs. We no longer have a baby in there causing the uterus to be distended and pushing and shoving our organs and things around out of its usual places. We may see a decrease in bowel tones for several days. They shouldn't be absent. And a lot of this is because of the decrease in peristalsis that occurs. Constipation is a huge fear of our clients because of what straining will feel like and how it can affect the perineal area. And hunger and thirst are quite common after delivery because of the dietary status that the client has during their labor and delivery process. A lot of clients are ice chips only, or clear liquids only, or nothing by mouth. Now, why would we see decreased peristalsis? Well, that's impacted by analgesics use, surgery, diminished intra-abdominal pressure, low fiber diet, insufficient fluid intake, and diminished muscle tone. Perinatal trauma and hemorrhoids will oftentimes increase the fear of pain with that first bowel movement post-delivery. So how do we help the client through this? Well, it is to administer any stool softeners or Synacot. I have seen a shift from, in some hospitals, from your Dulcolax stool softener to Synacot laxative, so that it helps clients to have a bowel movement. So you would administer those, either of those as prescribed. So during pregnancy, the hormones relaxin, estrogen, and progesterone relax the joints. So after birth, these hormone levels decline, causing a return to the pre-pregnant state for all the joints except for the feet, which is kind of crazy to think about because some women have a permanent increase in shoe size after delivery. It's not uncommon to see that. So all joints return to pre-pregnant state except for the feet. Fatigue and activity intolerance occur due to the decline in relaxin and progesterone levels. And this can continue for weeks after giving birth. So it's really important to educate your client to perform good body mechanics to prevent low back pain and injury to the joints. So it takes about 6 to 8 weeks postpartum for your joints to completely stabilize and go back to normal, except for your feet. Now, increasing uterine size causes stretching of the abdominal wall muscles and separation of the rectus abdominal muscles, or what we call diastasis recti, is more common in women who have poor muscle tone before pregnancy, but it can occur for women who have multiple gestation and other things, even if they had good muscle tone before. But abdominal muscle tone is diminished after birth, and special exercises will be needed to help return that to normal. Usually, diastasis recti will respond well to specific exercises. So we got to provide education on the exercises that can be started once they are cleared to start exercising and they're released from the provider. These clients need to be educated to avoid crunches, abdominal twists, planks, backward bends that stretch the abdominal area, certain yoga poses, or any type of heavy lifting activities that bulge out the stomach. So we're going to have the client focus on exercises that provide core compression. So that means squeezing the core in to draw the belly button in and up towards the spine while simultaneously and forcefully exhaling. So this involves exercises like pelvic tilts, toe taps, heel slides, single leg stretches, and bridges with belly scooping, where the patient engages their transverse abdominal muscles. So providers may also order an abdominal binder for the patient to use to kind of help with pulling those back together. Integumentary system adaptations. So the drop in estrogen and progesterone after the placenta is delivered helps the darkened abdominal linea nigra, the face melasma, and increased nipple pigmentation to fade over time. Some women also experience some hair loss within 3 months or so after giving birth. Usually this is a temporary thing, and regrowth returns within 4 to 6 months for some and up to 15 months postpartum for others. Striae gravidarum is stretch marks, and you will usually find striae gravidarum on breasts, abdomen, hips. They will fade, but they don't ever disappear completely. So while they may look more pinky red in the beginning, they'll fade to more silvery lines later on. And then, of course, diaphoresis is common for about a week postpartum. respiratory and endocrine system adaptations. So, with decreased estrogen, that's going to allow breast engorgement and diuresis. In the non breast milk feeding client, estrogen levels start to increase by 2 weeks postpartum. If the client is breast milk feeding, then estrogen levels remain low until breastfeeding frequency or pumping frequency decreases or stops. There is a rapid decrease in progesterone. It's almost basically undetectable levels by 3 days postpartum, and it's reestablished with the first menses after giving birth. Prolactin, when you see the hormone prolactin, I want you to think that's my milk making hormone. And we should see a rapid increase of prolactin after birth. That first spike in prolactin will influence the amount of milk produced for the client. So the higher the spike in prolactin, the greater the probability of adequate supply after breastfeeding is established. So that's why we want early feeding after delivery, especially if they're breastfeeding. Delayed breastfeeding or breast stimulation immediately after birth impacts how high the levels will spike up. Now, prolactin levels decrease after about 2 weeks postpartum in the non-breastfeeding woman. They will remain elevated during lactation in the breast milk feeding client. Oxytocin is our milk ejection hormone. It causes letdown and milk ejection. It's also your love hormone and your uterine contraction hormone. So, staying along the endocrine system, plus other placental hormones like HCG and HPL will also decline rapidly. And again, with the respiratory system, their tidal volume, minute volume, vital capacity, and functional residual capacity return to pre-pregnant values within 1 to 3 weeks of birth. And any anatomic changes that have occurred during the antepartal and interpartal phases will reside quickly. Lactation. So lactation is the secretion of milk by the breasts. It is the result of the interaction of progesterone, estrogen, prolactin, and oxytocin. The initial stage of lactation is reliant on hormonal influences and stimulation. So not just the spike in prolactin and oxytocin, but stimulation from the baby suckling at the breast, hand expression and massage, and pumping can also count as stimulation. Typically, what we start out with is the colostrum, which is usually a much smaller amount, but it is thicker and much more highly concentrated in nutrients for the baby. So it's perfectly made for the baby. And so the colostrum is what we have for our little ones when we breastfeed those first 3 to 5 days after giving birth. Now, we typically will see our colostrum start changing to mature breast milk anywhere from 3, 4, or 5 days after childbirth. It could be prolonged in certain situations like surgery, hypertension, eclampsia. There's other risk factors that could cause a client to have a prolonged phase of colostrum where it takes longer for that to transition to mature milk. So we would need to ensure that all clients are seeing a lactation specialist while not only in the hospital, but once they're discharged home. Now, just to kind of reiterate what the hormones actually do, estrogen stimulates the increase in the size of the ducts or the collection system in the breast. Progesterone stimulates the growth of the production system. Prolactin initiates milk production and it's released from the pituitary gland. And remember that in pregnancy, around the 16-week gestation time, the combination of those three cause the synthesis and potentially even a little bit of the secretion of colostrum, which is carb, protein, no fat, very heavy in antibodies. Oxytocin is your milk letdown hormone. It's released from the posterior pituitary gland. Any kind of stimulation to the breast, like the infant sucking, hand expression or pumping, will continuous stimulate the release of both prolactin and oxytocin. The breast crawl. So we know that skin to skin right after delivery is the gold standard following birth, and including the early initiation of breastfeeding. When a neonate is left undisturbed on the mother's trunk, that little one will naturally and instinctively shift, wiggle, push, and move up the mom's body to the breast to initiate self-attachment and the first breastfeeding. So you can actually go on the global health media network online or even search up breast crawl on YouTube. It's very amazing to see those little ones um, push and move and wiggle and get themselves up to the breast and bobble their head around, lick, and try to latch, and then eventually latch on, self-attach themselves without any help from a nurse or a lactation consultant. But it requires the baby to be in an awake alert state. So if we immediately take the baby and give them a bath before mom gets to do all these things, then that baby's going to have a really deep sleep phase and it's going to miss those first couple of hours or so of having their normal alert and rest pattern that they would go through. So, that's why, bathe the baby, if the parent wants it, but if they're breastfeeding, definitely would encourage to hold that bath for just a little bit longer so that they can go through their normal processes and have at least 1 to 2 good feedings before a bath occurs. Oh, goodness, engorgement of the breasts. I am just going to be the first one to tell you that this is so painful. It's the process of the swelling of the breast tissue due to an increase in blood and lymph supply as a precursor to lactation. You can also have engorgement not only when your milk starts to transition or when you're not breastfeeding and you're trying to dry your milk supply up, but you can have it if you don't breastfeed enough or empty your breasts. Because usually those first few weeks, a lot of mothers, not all, but there are a lot of moms that will initially overproduce before it levels off. This is engorgements relieved by either frequent emptying, doing warm showers and compresses before feeding, cold compresses between feedings. That's if you're breastfeeding. So if you're not breastfeeding, a nice supportive bra using ice and avoid all breast stimulation is going to help get through this. Um, so A on the bottom just is a picture showing engorged breasts. B1 is normal breastfeeding without engorgement. B2 shows a baby feeding on an engorged breast. So normally without engorgement, the infant's usually able to latch on and compress the areola and fit it neatly against their little lips against the breast tissue, and their little tongue will curl around the nipple and areola, and it allows for adequate feeding and breathing room. However, when we're engorged and trying to feed our baby, sometimes the engorgement's so bad that a person with everted or tips of the nipples that actually stand out good um, are basically flat, and it's like trying to latch a baby onto a bowling ball. There's nothing to grasp or very little. So they have difficulty latching and grasping the nipple. They get their nose smushed into the breast tissue, causing compromised breathing. And then mom or birthing parent's going to get improper or nipple trauma due to improper latching. And engorgement can lead to mastitis, which is a breast infection. Um, it can impact the staying engorged will impact the milk supply over time by tricking the body into thinking the baby doesn't need that much milk. So it's going to cause a decrease or a drop in the production and the supply as well. So we have to be very careful about that. Ovulation and the return of menstruation. So with the interplay of hormones, estrogen, progesterone, prolactin, oxytocin, um, we've got to pay attention. Is that client breast milk feeding, or are they formula feeding and non-lactating? So if they're non-lactating, the return of menstruation can take anywhere from 7 to 9 weeks after birth. If they are lactating, the return of menses is dependent on breastfeeding frequency and duration. It could be anywhere from 2 to 18 months. So sometimes this is dependent on whether the baby's getting a pacifier and supplementation or not. Is this client doing 8 to 12 good breastfeeding sessions each day? So those are things we look at. Cultural considerations. So in many other cultures outside of our Western culture in America, loss of blood in childbirth is considered hot and the postpartum period is considered cold. So the postpartum period must be balanced with hot, meaning physical warmth and or the intake of hot food and fluids while avoiding cold foods. And that could even be fruits and vegetables. Some cultures do not believe in the use of ice packs to the perineum or sitz baths postpartum. Some cultures also believe that postpartum women needs to remain confined for a certain amount of time, could be a month or so, in order to have the time to balance hot and cold. So you really have to be aware of postpartum beliefs and practices and customs. And we must be open, respectful, and non-judgmental um, about their differences in beliefs and their practices. Now, I will say that when it becomes a safety issue with the baby, there have been times where we've had to go in and the baby's been covered up in multiple blankets, on top of the clothes that they have on. And we're talking thick blankets, not just the thin receiving blankets. And then they've got a thick blanket over the top of the bassinet of the crib. And all they've got is just this one little sliver of a hole for airflow. So we walk in and we're like, oh, okay, uh, we've got to take some of these blankets off the baby for safety reasons. And it's not uncommon to have to go over safe sleep measures multiple times, even though within their culture, they are used to putting baby in lots of layers of warm clothing, lots of layers of blankets, and things like that. So we may no longer take some of those blankets away, rewrap the baby for them, and provide the education, do whatever else we need to do in the client's room, leave and come back an hour later and have to go through that whole same process again. So, all we can do is um, educate, make sure that the baby's safe, and document all of that. That not only shows that we've done what we were supposed to do, but it also covers you in the court of law should that baby smother. Um, so that they've been provided. Every time that you provide education, you have to remove items from the crib like that. You need to document that. So maternal psychological adaptations. Transition to parenthood causes the parents to face many new challenges, not only exhaustion, but overload and decrease in personal time and time for one another are some challenges that they must face. Sometimes even financial challenges if things didn't go the way they expected or hoped. We have to look at that as well. So, attachment is the formation of a relationship between a parent and his or her newborn through a process of physical and emotional interactions. We want to ensure that early and sustained contact between the newborns and their parents occur because this really is vital. And as a nurse, we play a crucial role in assisting with the process of attachment. So, some of the things we do, skin to skin contact is great in helping foster attachment and contact with the parents. It's not only the birthing parent or the mother that can do skin to skin contact, the partner of that birthing parent can do skin to skin contact as well. And we just need to teach them how to do it the right way. Leave the diaper on, put a hat on, put, warm blankets over the baby's back and put the baby directly to your skin, chest to chest. Um, Encouraging breastfeeding is another way to foster attachment. Sometimes you have parents that are on the fence of whether or not they want to breastfeed. All you can do is offer help and guidance. And sometimes they'll try it once and they're like, nope, I don't like that. That's okay. There's other ways to help encourage attachment. But if that one time they breastfeed and they're like, this is great, that has opened up a pathway that they may have not even really considered before because they weren't really sure whether they wanted to do it or not. Other ways to encourage attachment is encouraging the clients to um, participate in nurturing activities like just routine newborn care, touching the baby, talking to the baby, singing to the baby, comforting the baby, feeding the baby, changing their diaper. All of these things are nurturing activities that we want to see the birthing parent or mother and the partner do for that baby before they leave. Also, providing positive support and clear communication as the nurse can be very helpful with the attachment process. And there are some different factors that we know influence attachment. That includes environmental circumstances, the newborn's health, and the quality of nursing care. So be aware of that. So here's Reva Rubin again, maternal psychological adaptation, Reva Rubin's 3 phases. These are things you need to understand because you may see them again in the future, either through an exam here at school or the NCLEX. The taking in phase is that first phase. It's immediately after birth up to that 24 to 48 hours postpartum time. The mother depends on others to help meet her needs. She recalls and talks about her birth experience. Um, this phase does involve bonding and interacting with the newborn. So, like the mom using her fingertip to touch the infant, which is what we call fingertipping, gazing at her infant, holding her baby in her hands, which is called enfolding, calling the baby by name, identifying specific or unique features of the newborn. So, this is the taking in phase. That should sound familiar to you because it is part of your postpartum test out. Now, the taking hold phase is the second phase, and this is where the birthing client becomes as dependent and independent maternal behavior. So, it usually starts on the third or fourth day and can last for several weeks. Um, at during this time, they are taking hold of everything that's going on and becoming preoccupied with the present time. These birthing clients are going to express a strong interest in caring for the baby themselves. So they're not going to really want others doing that process for them because they want to do it. Now, the third phase is the letting go phase, in which the woman or birthing parent reestablishes relationships with others. They've adapted to parenthood and has an increased confidence as well as acceptance of their baby, their real baby, what they have in their arms instead of their fantasy baby that was thought about all those months during pregnancy. And their clients are more apt to actually have help with watching the baby so they can go out and about with a friend or with their partner for a brief time period. They may actually get out and do some mommy and me classes where they are meeting and establishing relationships with other new mothers. So just think about they've gotten used to doing these things with their babies, and now they're ready to um, get out there and reestablish their relationships with others because of their increased confidence in themselves as a parent. They're adapting as a parent and accepting their baby as who their baby is right now. Postpartum mood disorders. So there is a big difference between baby blues and postpartum depression. Baby blues, you'll see mild depressive symptoms, anxiety, irritability, mood swings, tearfulness, increased sensitivity, and fatigue. Baby blues usually peak around days 4 and 5 after giving birth, and they usually resolve by day 10. So this can last up to 2 weeks. Okay. Now, postpartum depression and psychosis are much different. The symptoms last longer and are more severe, and these birthing parents require treatment. It can lead to poor bonding, alienation from their loved ones, daily dysfunction, and if they get all the way to potentially psychosis, violent thoughts or even actions against themselves, their partner, their baby, their other children. So it's getting much more widely accepted of the fact that women and their partners have postpartum mood disorders at times. And there is less stigma now, more so than ever, in seeking help for depression after having a baby and things like that. So we just need to keep encouraging and educating about the difference between baby blues and postpartum depression and psychosis, and educate the partners so that if they recognize the symptoms before the mother does, that they're like, we've got to go talk to your provider. So there's no shame in it. Our bodies are going through so many different changes that physically, and we've had a lot of things change psychologically as well, that this happens sometimes. And sometimes we can't prevent it, but what we can do is treat it. And hopefully that's going to keep the birthing parent, the partner, the baby, and any other children safe. Variables that affect role attainment. As far as the mother is concerned, it could be with her confidence level, it could be age related, it could be her relationship with the father or her partner. Socioeconomic status can be a big variable as well. Their birth experience, especially if they had a traumatic experience, their stress level, what kind of support system do they have? Because if they have no one, that can impact how they attain their maternal role. Their personality traits, self-concept, their child-rearing attitudes, role strain, health status. How much did they prepare for this during their pregnancy? And then what is their relationship with their own mother? Is there depression and anxiety or a history of it? As far as maternal role attainment, when we look at the infant and how a birthing parent looks at their infant, the infant's appearance, if that newborn did not come out looking like what they thought, maybe it had a cleft lip or cleft palate. Maybe it has polydactyly or syndactyly of the fingers or extra digits. Maybe it has a very large port wine stain on the face. You know, the appearance of the baby can affect how the mother or birthing parent attains their role as the parent. What is the responsiveness of that newborn to the parent? What's the baby's temperament? And of course, their health status. So having the baby spend weeks and weeks in the NICU, that's traumatic to the birthing parent, the family, but that health status of the baby um, affects how that birthing parent attains their role as a parent. So, we've got to look at all of those things. And the partners, they go through um, developing a bond with the newborn, just like and attachment, just like the birthing parent. So, engrossment is the partner's psychological adaptation where they're developing a bond with the newborn. And it's where they're intensely absorbed, preoccupied, and interested in bonding with the baby. They're visually aware of the newborn, they have tactile awareness. Their perception of the newborn is seen as the baby's perfect. They have a strong attraction to the newborn. Um, they're aware of the distinct features of the newborn. They feel extreme elation by having this baby now in the outside world, and it can increase their sense of self-esteem. So, in developing the partner's role attainment or role development process, they start out with expectations. The partner is going to have preconceptions of what home life with the newborn is going to be. And they're going to be very unaware of how dramatic the changes could be once they're home with the baby, because it is a very eye-opening experience if they've never been around babies, if they don't have any children. Then they get to reality. This is where they realize that the expectations that they had while the baby was in the tummy may not have lined up with what's going on now. It can lead to feelings of elation all the way to sadness, ambivalence, jealousy, and frustration. They may not feel as prepared to help with the newborn or take on the parenting role. It can actually cause depression to appear within the partner within that first 1 to 3 weeks post delivery. And that can lead to relationship conflicts, violent behavior, poor job performance, substance abuse, and withdrawal from interacting with the baby and the birthing parent or their wife. Then we have transition to mastery. And this is where the partner is taking control and making conscious decisions to be present. So this is like that letting go phase for the mother. They're getting more confident in their role and in their ability to provide care for that newborn. So this is kind of what we see with the 3-stage role development process in the partner. Now, we got to look at typical assessments in the postpartum period. Some of these time values could vary depending on facility policies that you're working at. But in general, these are best practice guidelines. So within the first hour of the postpartum period, we need to be assessing the client at least every 15 minutes or less. Some hospitals, it's every 10 minutes for the first hour. During the second hour, at least every 30 minutes. During the first 24 hours, every 4 hours once we get beyond the second hour. And then after 24 hours, it's every 8 hours. The typical assessments, it's not only going to include vital signs and pain level, but it's also going to include the fundal check, the bleeding check, the perinatal check. So, and during the first hour and maybe through the second hour, it's going to be getting a quantitative blood loss where we measure the weight of the wet pads and linens and take the difference of that from the dry weight from the wet weight. And that tells us how many how much milliliters. Each gram of difference tells us how many milliliters of blood loss. So that's what we're talking about. So factors that can increase a birthing person's risk for postpartum complications. So this is box 16.1 in chapter 16. And as far as this box, and of course the reading about this is page 538 through 539. So risk factors for postpartum infection, that's going to include any kind of operative procedure, including an assisted vaginal delivery. So forceps use or vacuum extraction use. Does the client have a history of diabetes, including gestational diabetes? Did they have a labor that lasted more than 24 hours, so prolonged labor? Did they have an indwelling urinary catheter at any point? Did they come in anemic, or by the time they delivered or shortly thereafter, are they leaving with a hemoglobin less than 10.5? If they had prolonged rupture of membranes where their amniotic sac was ruptured for greater than 24 hours, did the client have to have their placenta manually extracted? And is there any compromise in that client's immune system? Active STI, HIV positive, things like that. Risk factors for postpartum hemorrhage include having a precipitous labor that's less than 3 hours, including a precipitous delivery where it delivers very fast. Uterine atony, where the uterus is boggy, and a lot of times uterine atony is caused by bladder distension. Placenta previa or abruptio placenta. So abruptio placenta is the same thing as placental abruption. Labor induction or augmentation is another risk factor for postpartum hemorrhage. That includes any medication like oxytocin use, and also could consider artificial rupture membranes as augmenting labor. Again, operative procedures, vacuum extraction, forceps use, cesarean birth. Retained placental fragments when the placenta is delivered, prolonged third stage of labor, where waiting on that placenta to pull away and deliver takes more than 30 minutes. Multiparity, where there's more than 3 births closely spaced. Uterine overdistension, where you've had a large infant, twins, or too much amniotic fluid called hydramnios or polyhydramnios. And then, of course, obesity is another risk factor. Now, postpartum danger signs, box 16.2. We have to teach our clients these danger signs to report. Fever greater than 100.4 degrees Fahrenheit, foul-smelling lochia or an unexpected change in color or amount of lochia, large blood clots or bleeding that saturates a peripad in an hour, severe headaches or blurred vision that does not go away, visual changes such as blurred vision or spots or headaches, calf pain with dorsiflexion of the foot, DVT, y'all, DVT, sudden weight gain, feeling faint, dizzy, or weak, rapid heart rate, swelling, redness, or discharge at the episiotomy, epidural, or abdominal sites, or laceration site, dysuria, burning, or incomplete emptying of the bladder, shortness of breath or difficulty breathing without exertion, depression, or extreme mood swings. So our vital signs assessment, our temperature, we can see a slight elevation during the first 24 hours, but it should be normal after that. And the elevation is slight. It's not usually significant. The pulse will usually go between 40 to 80 beats per minute, and puerperal bradycardia is known to occur after birth. Respirations should be 16 to 20 breaths per minute. The blood pressure is usually within that normal range for the patient. And our pain, the goal is to have a pain level between 0 and 2 on the pain scale. We know that if they had any kind of laceration, episiotomy, if they've had a tubal ligation where they went through the umbilicus or a cesarean section, they're going to have pain. And realistically, that pain is likely not going to always be a 0, even with medication. They may be 0 at rest when they're not moving, but once they start to move, it may actually increase. So our goal is to keep that pain level at the lowest level we can keep it. So hopefully between 0 to 2 on the pain scale. Postpartum physical assessment. So this is essentially your postpartum checkoff in a nutshell. With the breast, we're looking at size, contour, engorgement. We're also looking at the nipples. Are they flat, everted, inverted? Does the nipples have any bruising, redness, cracks, bleeding, blisters, if they're breastfeeding? We're looking for signs and symptoms of infection on the breast. And is the tissue soft, filling, or firm? For the uterus, we're checking the height of the fundus in relation to the umbilicus and its firmness. So remember to use proper hand positioning to note the location in relation to the umbilicus. Is the uterus midline or deviated, and what's the tone? Is it firm? Firm with massage, or boggy? We don't like it boggy and squishy. We like it firm like a grapefruit. Bladder. We need to know the last time that she emptied her bladder. Was it spontaneously or by catheter? Is she voiding? And when was the last time, obviously? Is the bladder palpable or not when we're palpating the abdomen? If she is urinating, what's the urine color, odor, amount, consistency? Bowels, we're checking the bowel sounds, checking for any abdominal distension that's abnormal for postpartum. What was her last bowel movement? Is she passing flatus? Is she hungry? Are her bowel sounds absent, hypoactive, normoactive, or hyperactive? Lochia, please make sure to use gloves when messing with the perineal area. Not a bad idea to use gloves just in general, but at least in that perineal buttocks area. So we're looking at the lochia amount, color. Are there any clots present? What's the odor? So is the color lochia rubra, serosa, or alba? Is the amount scant, small, moderate, or heavy? Is the odor kind of fleshy and earthy or malodorous? Episiotomy and perineum. So here is where we're looking for REDA. REEDA. That is redness, edema, ecchymosis, drainage, and approximation. Now, ecchymosis can appear similar to a bruise, but it's caused by bleeding underneath the skin, okay? So we're looking down in the perineal area, and sometimes if you can't see it from anteriorly, go ahead and turn the patient onto their side, and you can sometimes see better when we're looking while they're laying on their side. Plus, you can go ahead and look at their rectal area to see if they have um, any hemorrhoids. Is there a hematoma present down there? If there are in the perineal area, if there was a laceration or episiotomy that was repaired, we want it to be well approximated. And we want it to be free of redness, edema, ecchymosis, and drainage. And it's the same thing if the client was a C-section on their abdomen. For a C-section incision, we're checking for Rita. We want to see that the surgical incision is well approximated and that there's no redness, edema, ecchymosis, or drainage present at the site. Now, the extremities. We are checking for any varicosities, any pain in the calves or within the legs, any warmth or discoloration in the calves. Do they have pedal pulses? What's their sensation and movement of their extremities? If they had regional anesthesia or a C-section birth, are they able to move their legs and their hips and their toes? Do they have any edema on any of the extremities? So we used to teach students to check for Homan sign to help determine if there's pain in the calves, which could signify potential deep vein thrombosis or DVT. But that teaching over the years has sort of went by the wayside. And so what I will oftentimes do is ask the client, when you flex your foot, like you're pushing on a gas pedal and flexing it up towards your head, do you feel any pain or tenderness in your calves? Or if you're walking around your room, do you have any pain or tenderness in your calves? And then I'll physically look for any redness and feel for warmth. And all three of those are going to let me know, do we have any signs and symptoms of DVT or not? And then our emotions, we're assessing the birthing client's emotions and their bonding. What phase are they in? While they're with us, they're usually in that taking in phase. So fingertipping, gazing, and folding, calling the baby by name, identifying unique characteristics of the baby. And then, of course, is she having any signs or symptoms of postpartum blues already? Like, hitting that wall in the middle of the night at 2, 3 a.m., just crying her eyes out because she's lost and doesn't know what to do. And the baby won't feed, and the baby's crying, and she's just overtired and fatigued. Things like that. So again, this is sort of your postpartum assessment for test out. This next slide is some good pictures. Figure 16.2 comes straight from your book, and it shows that when palpating the fundus, that you should anchor or secure the uterus around that suprapubic area, and you're not pushing the uterus down towards the vagina. You are pushing in towards the spine as you're feeling for the uterus. And if you have to perform uterine massage for any reason, it's that circular massage. We're not trying to push the uterus down to expel clots. We're just trying to massage to get it to return to firmness from being boggy. So that is the far right picture. The top left picture shows a client's peri pad and panties. It's the disposable panties after delivery, and you can see actual large clots and that there's a heavy amount of bleeding on that pad. Now, we might look at this and say, when was the last time she changed her pad? Was she laying in bed for 5 hours and she didn't get up to go to the bathroom and change it? You know, what was the situation? Or was this within an hour since I last checked her? So the bottom left picture just kind of shows you lochia rubra versus serosa versus alba. So I think it's just helpful to see some pictures to understand what it can look like. Emotional status assessment in the postpartum period. How is the client interacting with their family and the baby? What is their level of independence? How is their energy level? Do they make eye contact with their baby? What's their posture and comfort level with the infant? What is their sleep and rest patterns? Be on the alert for mood swings, irritability, and crying episodes. And working night shift, it was quite common to walk in with the patient in the middle of the night to do a round, and having the patient just be sitting there crying, holding a crying baby, or the partner's holding the baby and the client's crying, and the baby's fussy and gassy. It's ate several times in a row, so she feels like she's starving her baby. So you just kind of have to remind that, well, the baby's woke up out of its heavy sleep phase and it just realized it's no longer in your tummy. So it's kind of it's getting a little overstimulated itself. It's not used to being laid in a crib. It's used to being tucked in where it's constantly being rocked and fed and from the umbilical cord. And it hears your heart sounds, your breath sounds, your tummy sounds. So it's never a true quiet environment in your tummy. And now we're putting it in a quiet environment and tiptoeing around it. And then just help with settling the baby, provide education on ways they can comfort the baby, and things like that. So bonding versus attachment, there is a difference. Bonding is that close emotional attraction to a newborn baby by the parents, and that usually develops in the first 30 to 60 minutes after birth. It is unidirectional from parent to infant, as an example. Attachment is the development of the strong affection between the infant and the significant other or the caregiver. It can be the mother, the father, the sibling, the caretaker of the child, anyone who that child has frequent contact, who cares for that child a lot. Attachment can occur. And of course, again, this isn't unidirectional. This attachment can go both ways, because as a caretaker, the more you're with a child, the more you get attached to that child, caring for it. Transitions to parenthood comes in stages, and there are factors affecting attachment. Of course, that includes parents' background, the infant, and care practices. So we've already kind of talked about this from chapter 15. so I'm not going to go over it again. Critical attributes of attachment and bonding, it includes proximity, reciprocity, and commitment. And then, of course, table 16.1, which is going to be coming up on the next slide, talks about positive and negative attachment behaviors. So let's take a look at that. This gives you the infant versus the parent, and it gives you positive versus negative behaviors. So as far as the infant is concerned with positive behaviors, they're alert, they smile, they have a strong grasp reflex to hold the parent or caregiver's finger. They suck well, feed easily, they like being held close, they make eye-to-eye contact, they track the face and the voice of their caregiver. They appear facially appealing, and they're generally consolable when they're crying. When it comes to the parent, positive behaviors include direct eye contact, assuming an on-face position when holding the baby, claiming that baby as a family member, pointing out the features of that child, expressing pride in their baby, assigning meaning to the infant's actions, smiling and gazing at the infant, touching the infant, naming the infant, wanting to be as close to the infant as much as allowed, speaking positively about their baby. Negative behaviors for the infant, they don't feed well, they regurgitate often, they cry for long periods of time, they're colicky and inconsolable. They have a flat affect. They rarely smile when prompted, they resist holding and closeness. They sleep with eyes closed most of the time. Their body is stiff when they're held. They're unresponsive to their parents. They don't pay attention to the parents' faces. These are negative behaviors that would signify that a parent would probably need to report these to their pediatrician, their baby's pediatrician. They may need to do some further investigation on what's going on with that child. For the parent, negative behaviors include expressing disappointment or displeasure with their infant. They're not exploring their infant visually or physically. They don't claim their infant as part of the family. They avoid caring for the infant and allows everybody else to do it. They find excuses not to hold the infant close or even care for the infant. They have a negative self-concept. They appear uninterested in having the infant in the room with them. They frequently ask to have that baby taken back to the nursery to be cared for. And they assign negative attributes to the infant and calls the infant inappropriate negative names. So those are negative behaviors that a parent can have. Factors that affect attachment, which we've talked about before, include their parent's background, the infant's temperament and health at birth, care practices, separation immediately after birth, policies discouraging exploring the infant, intensive care environment, and staff indifference or lack of support for the parents. So here are some teaching topics for the postpartum period. We need to teach about the client's pain and discomfort and letting them know that what those afterbirth pains are, if they've had some sort of surgical or assisted delivery, that their pain level, our goal is to get it between 0 and 2, but it may not go away completely, especially when they move around. Immunizations that may need to be considered to be given after birth, like the Tdap, especially with pertussis on the rise. Nutrition and what that's going to look like for them post-delivery. They need good protein to help heal, but they also just need to eat a good diet according to their diet restrictions or preferences. If they're breastfeeding, they're going to want to ensure that they're drinking 2 to 3 liters of water all fluids count, but water's better a day, and increase their calorie count by about 500 calories daily. Talk with them about activity and exercise, the do's and the don'ts in the early postpartum phase versus once they're released from their provider, usually after 6 weeks postpartum, and then lactation, whether they're breastfeeding or not, milk supply is going to happen. And what do we do with engorgement? If you're not breastfeeding, the things that we talked about earlier that we need to educate the client on, versus if you are breastfeeding, these are the things we're going to teach the client about how often they should feed, that feeding frequency, ensuring that they have at least a manual or an automatic electric breast pump available for their use if they need it in case of emergency. Breast milk storage guidelines, breast care, and signs and symptoms to report. Of course, discharge teaching for the client for their postpartum care, self-care. Also, postpartum blues versus postpartum depression, and signs and symptoms to report to their provider. We also need to discuss sexuality and contraception. Typically, we tell clients nothing per vagina. No douches, no intercourse, no vaginal toys, nothing like that until after their 6-week checkup when they are cleared by their provider. And of course, do they have a want or a need for contraception? And getting them to talk with the provider before discharge to home. Because sometimes, especially if they're not breastfeeding and they want like the Depo-Provera shot, sometimes that can be started before they go home. And then when are they supposed to follow up with their provider? Cesarean section delivery typically will follow up with within 1 to 2 weeks, and a vaginal delivery, depending on what is going on with that client, it's anywhere from 4 to 6 weeks postpartum, but could be sooner if needed. Also, if they're breast milk feeding, following up with a lactation specialist or consultant after delivery, whether it is at a private clinic or the health department, is quite helpful as well. When it comes to nursing management in the postpartum period and nursing interventions, please be aware of the different cultural practices when you're planning and caring for your patients. So if you're not sure about their culture, don't hesitate to ask and don't hesitate to look things up so that you can make an appropriate care plan and teaching plan. You want to provide optimal cultural care, promote comfort, cold and heat applications as per the provider's orders, topical preparations as per the provider orders. So it may be a Dermoplast spray or a Dobucane gel to their vagina, witch hazel pads that they can line their peri pad with till they feel much more comfortable. Any kind of analgesics that the provider provides for them. Sometimes it's PRN, other times it's around the clock, but always asking, I know that this is scheduled. What is your pain level? Do you want your pain medication? It is scheduled to be given to you within X amount of hours around the clock. And then, of course, if they don't want it, you can put the client refused the need for pain medications at this time. If they do want it, of course, you would go through the steps and you would administer that pain medication appropriately according to the provider's orders. And you would also go back and reassess the pain value and document that appropriately. Assisting with elimination. So typically they're not getting up to the bathroom by themselves for the first 1 or 2 times after delivery. We want to ensure that we don't have any falls. Even if they had a natural delivery, we are accompanying them to the bathroom, and we're going to educate them on how to get their pad ready to put it in their mesh panties and about using their peri bottle and everything like that. We need to promote voiding. So I typically tell my clients that during the daytime hours, make sure you're getting up and attempting to empty your bladder every couple of hours because that gets them up out of bed. They won't stay in bed if they get up and walk around the room and go void and do pericare. And then, of course, at nighttime, if they wake up in the middle of the night to feed their baby, they may want to go and empty their bladder and do pericare once or twice through the night as needed. Promoting bowel elimination. So, providing the client and administering their either stool softener or laxative as per the provider's orders, as long as the client wants it. And, you know, teaching the client about what it may look and feel like when they have their first bowel movement after delivery, that sometimes they don't even have one before they leave the hospital. It's when they get home. Promoting activity, rest, and exercise. Early ambulation is good for clients. We typically don't want our clients to stay in bed for long periods of time, except for when it's their sleep time at normal sleeping hours, because we want them to get up and move around and prevent pneumonia or deep vein thrombosis. We want them to not do too much and give themselves rest periods and rest when their baby rests. And then provide them with the recommended exercises and Kegel, however you want to say that, exercises, while letting them know that before they do anything drastic or along the lines of exercising, they need to be cleared by their provider to participate. They can do Kegels, but anything else beyond that, they probably won't be able to do until their provider gives them the go ahead and says that they're cleared to resume normal life. Assisting with self-care measures is important. Ensuring their safety. These clients, oftentimes, especially right after birth, whether they've had an epidural or not, they can be prone to be a falls risk, pass out and fall, things like that, especially their first 1 or 2 showers that they take. They may have the water too warm and then feel like they're going to pass out. So we need to ensure safety and escort them to the bathroom and ensure someone's in the room, maybe not necessarily in the bathroom, but in the room while they're showering. And then counsel about sexuality and contraception. Ensuring safety during ambulation. We always need to check their blood pressure first. Then make it a stepwise approach. Elevate the head of the bed for a few minutes before ambulating. Have the client sit up, turn, and sit on the side of the bed with their legs dangling for a few moments first. And then to stand up slowly while looking forward, not looking down. And we should help her with that and stay with her. We need to ambulate alongside the client and provide support if needed. Sometimes we can do it just one person, but most of the time it's their first time getting up. It's better to have 2 people helping. Frequently ask the client how she's feeling. How does her head feel? If she's had an epidural or spinal anesthesia, then pay attention, because sometimes deep down in their hips, it can take a lot longer for filling to come back there and they don't realize it. So that can cause them to actually fall. And then stay close by to assist if she feels lightheaded. So a lot of times when the client was in the restroom, after they've voided in private, I leave the door unlocked until I'm just right outside the room. I'm usually, changing their bed pad, straightening up their bed, and just kind of hanging out and asking them every so often, "Do you feeling okay? Are you ready for me to come back into the bathroom with you yet to do some teaching?" And so then I'll enter back into the bathroom when it's time for me to go back in there and teach about pericare and then assist the client back to bed. So promoting nutrition, of course, we have general recommendations and the needs for the breastfeeding woman. And I sort of talked about this already, but I want you to remember that we always need to be supportive of the client's chosen feeding method and provide assistance, whether it's with breastfeeding or bottle feeding or pumping their breast milk and feeding. There are only a few instances where here in the United States, it is not recommended to breastfeed the infant. It for certain drugs like antineoplastics and street drugs like methamphetamines, PCP, certain diseases such as HIV positive or active herpes infection on the breast or nipple. And then newborns with issues like errors of inborn metabolism, such as PKU or galactosemia. I will oftentimes, especially when it comes to HIV positive parents, I print out the CDC guidelines regarding not breastfeeding their baby while HIV positive. Now, I can educate them all day long while they're here against it, but they might do what they want to do when they get home. Now, if they're really insistent on breastfeeding, um, first off, I provide them with the education and I let them know that I have to get permission from their baby's pediatrician or neonatologist who's seeing them in the hospital first. And so at that point, I will offer a breast pump or assistance with her getting a breast pump if she doesn't already have one, and if the hospital has that capability. And the hospital that I worked at did. And so get her set up with a pump and educate her about pumping and that she doesn't have to pump and dump. She can pump and store, but she cannot feed it to her baby right now until I talk with the pediatrician. And it's going to be something that she's going to have permission not only from the pediatrician, but when she leaves, follow up and permission with her infectious disease provider. We also, when it comes to breastfeeding assistance and education, we not only need to assess the mother's breast, but we need to assess the baby. We need to check their oral anatomy for any tongue, lip, or cheek ties where it's really tight and they struggle to latch properly, and observe at least once a shift latching and feeding itself, even as the nurse, because you have to document about it. We also need to educate the client on the stomach size and the changes from birth to the first week or beyond. Because the baby's stomach size is about the size of a cherry or a shooter marble at birth. So, depending on the baby's size, they could hold anywhere from 5 to 10 milliliters of fluid per feeding, which is why the amount of colostrum they get is usually perfect for the baby, unless they're having issues. with hypoglycemia and things like that. And sometimes it may not be enough to sustain blood sugar for long periods of time if they're not feeding appropriately. We have to talk about the mechanics of breastfeeding, like positioning, latching, and of course, may include any tools that can be used, like nipple shields, breast shells, or supplemental nurture system, um, for when they're having to supplement with donor milk or formula. And they can actually feed with that at the breast. Expression of breast milk, either by hand, manual pump, or electric pump, including breast milk storage guidelines. And pump flange sizing is huge when it comes to having a good pump session, because it can impact the comfort and the expression of milk for that birthing parent. So they need to have the appropriate size flange in comparison to the tip of their nipple size. And this may need to be rechecked throughout their breastfeeding journey, because what they need right after delivery may be different than what they need for 2 months from now. And then talking about a person who wants to breastfeed but may not be able to produce milk or adequate milk supply. So we're going to talk about even our transgender population, male to female. Our clients who's had breast reduction that severely altered the internal components of the duct system, leading them to not be able to produce the milk or actually have milk come out, especially if the ducts and things were severed, if the nipple was cut off and reapplied. But we are seeing more and more about providing, like even our transgender biological male to female patients wanting to feed at the breast. And while it is not totally impossible for a biological male to actually produce milk, it may require uh, lots of hormone replacement therapy and lots of stimulation and other medications to get the process started and resume the process as a male, because biologically a male doesn't necessarily produce these exact same hormones that we do and the levels needed to actually produce milk and maintain a milk supply. So they're going to require close follow-up with lactation. And until actual lactating breasts on that transgender client is observed by the lactation specialist, then it may be that we're using a supplemental nurture system with donor milk or formula at the breast to continue breast stimulation. And then what about the parent who has adopted a child that wants to breastfeed, or a parent who is in a lesbian LGBTQ relationship, who is biologically female but didn't birth the baby. So it is possible to cause lactation in the female with consistent stimulation and maybe even certain medications like Reglan or things like that to help produce milk. So So while it's rare, sometimes people who are not pregnant or nursing can produce milk from their nipples. Um, and when they do it without assistance, it's usually a sign of an underlying issue. Um, with assistance to cause lactation, though, um, we would need to be very cautious about how much milk is being produced and is it enough to be, sustain that infant's life and caloric and dietary needs. Um, Here on box 16.3 are recommendations for nutrition during the postpartum period. And it's just giving you lactating person versus non-lactating person. And while this goes by the My Plate, and we're talking about the way the food guide pyramid used to be, um, this doesn't take into consideration the new change to the food guide pyramid. So, for testing purposes, go by what's in your book, but be aware that when NCLEX comes, by that time for you, they may actually have the new nutritional guidelines when it comes to the food guide pyramid and things like that updated on the NCLEX exam. But in general, we should ensure that for breast milk production, they increase their calorie intake by about 500 calories per day. They increase their protein to 20 grams per day. And that could be as simple as adding an extra couple of cups of skim milk. Excuse me. Um, then calcium increased to 400 milligrams daily and increase their fluid intake and avoid sodas and too many sugary drinks. So it's really important that they're getting adequate fluid intake, especially whether they're lactating or non-lactating. Teaching Guidelines 16.5 give you good information regarding the suppression of lactation, but we talked a little bit earlier about breast assessment and measures to alleviate breast engorgement for the lactating and the non-lactating client. So I'm not going to go over that again. Promoting family adjustment. So this includes not only the parental role, but our sibling roles and our grandparent roles. We need to ensure that if we have older siblings and a new baby has come into the picture, that as a parent, we are giving the older siblings some one-on-one time with the parent or the birthing parent every day, even if it's just, 30 minutes for bath time and a book after at bedtime or something, where it's just you and that child, and do that for each child you have. It can be very distressing for some children, especially if they're an older child or an only child who's the older child, or this is a child who didn't want another sibling after them because they quite enjoyed being the baby. So we have to always take that into consideration and give them little jobs to do that's appropriate for them to, age appropriate for them to do. That's a big important thing for the siblings, to make them feel like they're a part of caring for that baby within their age limits. And grandparent roles. Um, Grandparents are an important part of a child's life, especially if they're willing and wanting to be present in that child's life as they grow up. Um, so some grandparents are great about not being too pushy and um, to trying to be in charge of everything over the parent and providing not providing unsolicited advice. Other grandparents don't do so well. Um, but a lot of times things can be handled in a respectful manner. And while a grandparent may get their feelings hurt for a moment, if they're invested in being in that child's life and being in your life, then they should be respectful of how you're raising your child and being a support for you and for that child. Um, Postpartum blues. We talked about this already, but I just want to stress that postpartum blues are typically transient emotional disturbances. Transient meaning that they usually resolve on their own without help from medication or anything like that within 10 to 14 days or so after delivery. Um, so it can, even for some clients, it can resolve much sooner. So it just depends on the client. Blues, especially when the client has restorative sleep and they're able to sleep well, their postpartum blues typically start to decline and go away. But it's characterized again by anxiety, irritability, insomnia, crying, loss of appetite, sadness, things like that. Postpartum depression and psychosis are much more serious, and that requires professional referral and treatment. Again, when we're preparing for discharge, number one, we're looking at criteria and has the client met the criteria to be discharged? And so for this, we're looking at, are they a febrile with vital signs that are within normal limits? Is their lochia appropriate in amount and color for the stage? Is their hemoglobin and hematocrit within normal limits or close to being normal limits? Is their uterine fundus firm with adequate urine output return? Did they get their ROGAM if it's indicated to administer for Rh negative mother with a positive antibody screen and a positive Rh baby? How is their surgical wounds healing? Are they showing any signs and symptoms of infection? Because if so, then they shouldn't be going home. Are they ambulating without difficulty? How is the client's intake? Is it normal? And are they taking in their foods and fluids without difficulty? What's their self-care and infant care like? Are they understanding and demonstrating both appropriately? What are their support systems available for discharge when they're at home? And is the mother aware of possible complications for her or the baby and signs and symptoms to report? Um, has the immunizations been discussed and updated? So, like the Tdap, for instance, can be given before discharge if she's not opposed to receiving it. And then ensuring appropriate follow-up care. So a telephone follow-up phone call is usually provided within 1 week postpartum, just to check on the client. Outpatient follow-up includes a clinic visit. And again, for a cesarean section, it may be in 1 to 2 weeks after delivery. And then again, maybe at 6 weeks. For a vaginal delivery, usually between 4 and 6 weeks postpartum or sooner if needed. And then home visit. Some clinics will do a home visit. We see more often it's lactation doing home visit from either the health department or a private lactation clinic versus a home visit from their OBGYN office. Now, home visit could be from a nurse midwife or a lay midwife. If the baby was born in a birth clinic that's not attached to a hospital, they may actually perform a home visit follow up. instead of having the client return to the clinic, to the birth center. And then box 16.4 are challenges facing families after discharge. Um, and lack of role models can be huge, especially with the breastfeeding client and for infant care. Lack of support from the birthing parent's own birthing parent if they did not breastfeed. Increased mobility of society. So the extended family may live far away and can't help care for the newborn and support the new family. Non supportive, overwhelmed, and fatigued partner. Feelings of being isolated and limited community ties for birthing parents who work full time. Shortened hospital stays. So it is not uncommon for a first time parent, first baby ever, to be sent home within 24 hours after giving birth, where many, many years ago, they stayed for at least 2 days. Some clients who it's not their first baby and they want to go home before 24 hours is up are being cleared to go home anywhere from 12 to 18 hours after delivery. So parents can also be overwhelmed by all the information they're given during that brief hospital stay too. Prenatal classes usually focus on the birth itself rather than on the skills needed to care for themselves and the newborn during the postpartum period. And so I was very conscious of this when I used to teach the childbirth classes here at the local hospital I used to work at. And I not only went over, what's going on during the labor and birthing process, but we went over postpartum care and I showed it, examples of things that they may be taking home with them and talked about how to use them. We also went over newborn care, including breastfeeding, bottle feeding, and formula feeding and pumping. So that included bathing the baby, how to dress the baby appropriately, safe sleep, making sure you have an infant car seat when you come into the hospital to deliver, things like that. Just to help so that they've been talked about if they attended the birthing class that I taught, so that they at least were talked about this, and then let them know that I would be there to see them. That, whether it was me working in the nursery or the NICU or me doing lactation. So, because at the time, that's what I had moved on to from labor and delivery. And then limited access to education and support systems for families from diverse cultures. That's a big one too. Um, so, we always have to think about that as well. So, thank you for hanging out with me to go over chapters 15 and 16 over giving you a good postpartum boot camp. I hope you enjoyed this. I know it was long, but we basically spent an hour for each chapter. So I appreciate you hanging out and listening to all I had to say. Have a great day.